Hi, Mr. Flynn. My name's Amanda. I'll be your practitioner today. We're going to go ahead and do an exam on your lungs and your heart.
Okay.
Okay. Go ahead and remove your shirt for me. To start out with a lung exam, we're going to do that first. Patient's skin looks fine. We don't see any venous malformations. The color looks good. Patient isn't having any difficulty breathing or shortness of breath. I don't see any problems with intercostal retractions. Patient does have a pectus exclavium, which is a congenital deformity, which is of no relevance because it has not caused an issue for the patient in the past, cardiac or respiratory wise. Go ahead, and the trachea is midline. The substernal subcostal region is looks good. The angle of Lois looks well. Bend your head down for me. Looks like C7 and T1 are intact. Okay, so we're going to go ahead and I'm going to percuss your lungs. Okay, so I just want to listen to what I hear first, and then I'll have you do a few things for me. Okay?
Okay.
So I'm going to go ahead and percuss down the lung borders, listening for resonance and or dullness. Go ahead and do this on the back, sir. We are avoiding the patient's scapula. You go ahead and turn just a little bit for me, sir. I want you to take a big deep breath in. And what I'm measuring is diaphragmatic excursion, and just hold it. Take a big deep breath in, hold it for me. We'll go ahead and mark that with a pen. And then you can take a deep breath and relax. One more time. Okay, and relax. Take a deep breath in and blow it all the way out. We measure between the two markers to see, it looks about 6 centimeters, which is normal for the patient of this age. You turn forward towards me. I'm going to go ahead and we're looking for tactile fremitus. As I put my hand on your chest, I'm going to have you say 99, okay?
99. 99. 99. 99. 99. 99. 99, 99, 99, 99.
I don't feel any tactile fremitus. Go ahead and listen to the patient's lungs. As I put this stethoscope down, I want you to just take a deep breath, sir, and in and out. Put your arms up just a little bit, sir. And go to the posterior side. Going to go ahead and palpate for any type of crepitus, which is air that's trapped underneath the skin. I don't feel any crepitus anywhere. There's a couple other tests that we could have you do as I'm listening. If you could say 99 for me just once, please.
99.
It sounds very muffled, and that's normal. We'll go ahead and you say E.
E.
If it sounds like A, that might mean that there's some consolidation underneath that area, which would be indicative of cardiac. I don't hear any rhonchi, wheezes, or rubs. We'll go ahead and we'll move on to the cardiac evaluation. Same with this. We're going to go ahead and at first have you lay down, please, with your head here. Okay, with the patient supine, we'll go ahead and have the patient turn to his left side. No, just your head, sir. Okay. What I'm looking for is the JVP, or jugular venous pulse. We'll go ahead and find and locate where that is at. We can take a straight edge and a ruler actually and measure the angle. We'll pretend that I have one and it's 3 centimeters, which would be normal. So you can go ahead and lay back. I'm going to go ahead and palpate both carotid arteries one at a time. What I'm feeling for is any kind of thrills. I feel a good pulse. We go ahead and listen with our stethoscope with the bell, and this particular stethoscope has both for listening for carotid burides, which I don't hear any. So we're going to go ahead and palpate the chest to start with. We go ahead and palpate at the 5 impulse points that we need, which is the aortic, which is in the second subclavicular or second intercostal space. Is your aortic over here. Is your pulmonic, 3rd space. Secondary pulmonic, 4th space. Tricuspid. 2, 3, and 4 are also known as Erb's point. Go ahead into the midclavicular line, and we'll go ahead over here, which is the apex. And what I'm trying to palpate is to see if there's any heaves or thrills, which would indicate a negative indication. We're going to go ahead and we'll percuss for the boundaries or the borders of the heart. This is really not as diagnostic as a X-ray. Heart seems to be in a normal size. We'll go ahead, and while he is in this position, we'll go ahead and listen to his heart sounds. We're going to listen for S1 and S2 and any abnormal sounds. Go ahead into the second intercostal space, so the aortic. The bell and the diaphragm both is to be used at this time. For this purposes, we'll just say that we've used both. Go ahead to the second, the left side of the substernal border, which is the pulmonic. Secondary pulmonic, which is the 3rd. Tricuspid. And then mitral, which is the apex of the heart, which is in the 5th. Sir, if you could just turn to your left for a moment, please. So we're going to go ahead and listen at the pulse of maximum endpoint, which is actually at the apex. Turning the patient to the left actually brings the heart closer. I do not hear any murmurs. S1 and S2 are clear. No sounds of S3 or 4. No rubs, no gallops. Okay, sir, if you go ahead and sit up for me. I'm going to go ahead and listen to you again, but I want you to lean forward for me a little bit. So we will listen again at the aortic, pulmonic, which is the second subintercostal space, the 3rd intercostal space, the 4th intercostal space, and the 5th. S1 and S2 are normal, no splits, no rubs, no gallops. If I was listening for a murmur, I would want to know the exact timing, duration, intensity, location, and variation with any kind of respiratory variation. And that concludes our evaluation of the cardiac and respiratory systems.